Nadia Matama for Monta.
Right, class reps, I'll share the YouTube link to on the WhatsApp page, so kindly check and share on your pages. All right, so as usual, you have been muted and only the class reps can unmute themselves. So class reps, please mind your microphones, okay? And then lastly, those of you on YouTube, please note that you can type your questions there and I will address them. So continue our discussion on the respiratory system. Okay, so that's it. So a very quick audio test. If you can hear me loud and clear, please give me a thumbs up. Okay, use the reaction buttons to give us a thumbs up. Those of you who are struggling to hear, you have the option of joining the YouTube. Okay. Jibrila, am I loud and clear?
Yes, Doc.
Okay. Jay can hear me. Abigail Amo, can you hear me? Okay. All right. All right. So then we are good to go. All right. So with discussions on the respiratory system, the last time we met, quite a long while ago, we were able to look at the functions of the respiratory system. If you missed it, the video is there on the Telegram. So the functions of the respiratory system, we went through that, and I beg you, my voice is not down, so kindly increase your volume. We went through the functions as the exchange of oxygen and the removal of carbon dioxide. We saw it works with the cardiovascular system, all right? it picks the oxygen and sends it through the blood down to your tissue level. And when it gets to your tissue, the blood releases the oxygen into your tissues and picks up carbon dioxide, brings it back into the heart. The heart will send it to the lungs for refreshment, and then it is refreshed. And when it is refreshed from the lungs, it comes back to the heart, and then the heart repumps it around your body. People are saying my voice is low in the chat room. Is that the same for everyone? Class reps, please confirm. All right. So please, if you cannot hear, increase your volume. If you're on YouTube too, YouTube has a volume. All right. There's a volume there at YouTube that you can increase. So kindly do that. Okay. Those of you are asking me to record, yes, I'll record. It's just that I'm doing an overview now. Okay. Thank you. Even those on YouTube can hear me loud and clear. They also can hear. So let's go on. Right, so we saw the function of exchange of gases, and then we saw that as the air is going through these airways, the air has to be purified, it has to be warmed, and then it has to be humidified. The body has a way of introducing some moisture into the air that we are breathing in, okay? We looked at that and how it does it. We saw the organs of the respiratory system, the nose, the pharynx, the larynx, trachea, the bronchial tubes, the lungs, the alveoli. We saw them, and then we also appreciated that all these organs are divided into two zones based on their functions. That's the first one is called the conducting zone. Conducting zone, let me make a correction here. That is from the nose, okay? From the nose all the way, all the way into terminal bronchioles. And their function is just to pipe the air down. And then there is a respiratory zone that starts with, after terminal bronchioles, you are going into respiratory bronchioles. So respiratory bronchioles all the way down to your alveoli level. That is, these are the sites of gaseous exchange. Over there, the membrane is very thin, even thinner than paper. Very, very thin, so that air molecules or oxygen and carbon dioxide molecules can easily cross and exchange with blood. Right, so that is the conducting zone, and then the respiratory zone. We looked at the nose, we discussed the cavity, we looked at the structures inside the nasal cavity, the hair, filtering dead particles, the capillaries there in the membrane, bringing warm blood there so that as you breathe in the air will be warmed, because you don't have to breathe. The air reaching your lungs doesn't have to be cold. It should be warm. And if it is cold, there will be damage to your lungs and airways. Then we saw the paranasal sinuses. We even looked at the detection of the sense of smell. It's also a function of the respiratory system. The structure is within the nasal cavity and the roof of the nose, all right? Very close to the roof of the nose where the olfactory epithelium is. Then we saw paranasal sinuses as hollow spaces distributed around the nose. They are also lined with respiratory epithelium. And we said respiratory epithelium is pseudostratified columnar ciliated with goblet cells, okay? The goblet cells produce mucus that help to trap dust and particles, debris that may be in the air that we are breathing in. And then we also said that the paranasal sinuses also help make the skull light. And when we breathe, the air goes through them as well. Also, when you speak, they help in resonating your voice and modulating your sound, your voice, and making it nice and clear. Then the pharynx and then the throat, we went in there. We said it's divided into 3 portions based on their connections to the structures in your head. Over here is connected to the nose. So we say nasopharynx. This side is to the oral cavity. We say oropharynx. This side is to the larynx. And so we say the laryngopharynx. And we said there was a structure in the larynx we call there's eustachian tube over here. Some call it the auditory tube. Some call it the pharyngotympanic tube. It connects the pharynx to the middle ear, the tympanic cavity. And we said it helps, the function is to allow air to go into the middle ear to balance the pressure inside your middle ear. It is also clinically, it can also facilitate the transfer of infections from your middle ear into your pharynx and from your pharynx into the middle ear. And so in children, you find that in children, ear infections are very common because they have a very short pharyngotympanic tube. It's very short and more horizontal. So transfer is very easy. And you find them getting ear and throat infections, very common. And then, so we even demonstrated that when you put ear drops into your ear, you can taste it in your throat. That's that awkward feeling. We also talked about those who like to clean their ears using feathers, it tickles them when they are doing that, and you find them doing, and you wonder the connection between the throat and the ear. Yes, it's because of these connections. Yeah, so we talked about that. We went into the larynx. We said the larynx is the voice box, and it's a cartilaginous voice box. It works like a guitar. There are 2 cords inside the larynx, the superior one is called the false vocal cord. The inferior one is called the true vocal cord. And we said the true vocal cord vibrates to produce sound. And they vibrate just like a guitar string will be producing sound. And here we agreed, or we said that the vibrations are produced by the air as the air is coming up and down the larynx. As the air is coming up and down, it is beating the true vocal cord and is vibrating, and it will produce the sound. The sound comes through your mouth, the tongue, the lips, and the teeth help to shape the sound into words, and you speak words. All these are controlled in the brain. And the nerve that controls your vocal cords is called the recurrent laryngeal nerve. When that nerve is cut, accidentally it is cut during thyroid surgeries, because you have the thyroid gland sitting right in front of your larynx. This is one of the cartilages of the larynx called the thyroid cartilage. It's the one that produces the Adam's apple in your neck. This is the area that protrudes in your neck as the Adam's apple. So the thyroid gland is attached to this area. So thyroid surgeries, they are not very careful. They can cut your recurrent laryngeal nerve accidentally, and then you lose your voice. Right, so we talked about that. And we looked at vocal production. And I think that is where we ended our discussion on the respiratory system the last time. When you get the videos, for those of you who missed the lecture, these are the things that we discussed, and the video will throw more light on that. So get to the Telegram platform so I can record from this point for you. Okay. Right, so from the larynx, we are moving into the trachea. So this is the larynx, sitting there beautifully. That's a thyroid cartilage of the larynx. This is the last cartilage of the larynx. We call this the cricoid cartilage, the cricoid cartilage. That's the last cartilage of the larynx. So the trachea begins at this level. So that's the beginning of the trachea, okay, in your neck. We say it begins at vertebral level C6, at the level of the 6th vertebral level, the vertebra of the neck, 6th cervical vertebra. That is where the trachea begins. So your trachea is over here. There's a picture. Okay, so that's the trachea, runs down from the neck into the chest, and then at this point, it bifurcates into two, giving us the primary bronchi. The point at which it bifurcates occurs at the level of T4, the 4th thoracic vertebra, okay? Or some will say just between T4 and T5, between the 4th and the 5th thoracic vertebra. And that level also coincides with your sternal angle, okay? There's a protrusion on your sternum. Just a moment. Right, so the level of your sternal angle, okay, in your chest, you can palpate your chest here, locate a depression here we call the jugular notch. Call it the jugular notch, okay? It's on the manubrum of the sternum, and then palpate it. When you palpate it downwards, okay, in the midline here, palpate it downwards, you feel a bump there, a bump at a point. There's a bump here, right? This is where mine is. You'll find yours somewhere over there, okay? That is what we call the sternal angle. We also call it the angle of Lewis. The angle of Lewis is a junction between the manubrum and the body of the sternum. So it protrudes forward like that, okay, giving you that bump. So that is where, that is the point where the trachea will bifurcate and give you the right main bronchus and the left main bronchus. Right, so trachea starts from C6 to T4, okay, roughly. Now you notice these rings around the trachea, okay? These are cartilaginous rings, okay? They are made of hyaline cartilage. They are cartilaginous rings, and you find them all around the trachea and then the bronchi. Their purpose is to hold the trachea always open, okay? Breathing is very essential. I mean, you can't stop breathing. You have to breathe until you are dead, okay? Breathing stops when you die. And so the body has to make sure that your trachea is also called the windpipe. Your trachea is always open and allowing air to flow through it easily. That is why there are cartilaginous rings inside your trachea. It said they are made up of hyaline cartilage. You know, cartilage is not bone, all right? Although it is firm, but then flexible too. So it's a very good candidate to form the wall of your trachea. And they appear in rings. So we are looking at it in the anterior view. You would think that it will go around it. It doesn't go all around it. It is like this. They are C-shaped, okay? The cartilage is a C shape. So in the anterior, you see it complete, but in the back, there's a space there, and that space is filled with a muscle. So let me show you a posterior view. This is a transverse section of the cartilage, okay? The trachea. It's like we've cut it like that. That's a transverse section of it. And so we can see the C-shaped cartilage. That's a cartilage inside the wall of the trachea. So anteriorly is complete, but when you go to the back, there's a gap there, and that gap is filled with smooth muscle. The muscle here is called the trachealis muscle. Right behind the trachea is the esophagus. And so we also discussed why food will not go into your larynx, but go into your esophagus. We discussed that, and we also discussed why and how choking occurs. We said when you are speaking and eating at the same time, you are likely to choke. It's very easy. So don't speak when eating. Observe table manners. Right. So these are some of the things we've talked about already, and they are in the video. So esophagus is sitting right behind the trachea. So this design is strategically done to allow the esophagus to expand when you are eating, okay? If the cartilage was continuous all around, it was going to limit the lumen of the esophagus. And so it will be very difficult to swallow. But with this gap left here and filled with smooth muscle, it means that the esophagus, those of you who like contour, large muscles of food, the esophagus can stretch nicely into and then occupy some of the space over here, all right? It will push slightly into the lumen of the trachea so that your food will go down nicely without obstruction. And so those of you who take a lot of fufu, you realize that when the muscles are very large, the contour is very large, to be going at the time it's going in through your esophagus, breathing is quite restricted, all right, because it's pushing against the trachea. But it will still go down nicely once it's fufu. If it is meat, that is when the wahala can occur. Right, so that is how the trachea is designed, okay? Right. The mucosa of the trachea, the epithelial lining is pseudostratified columnar ciliated with goblet cells, okay? The goblet cells are there and the ciliated columnar cells. The cilia on the cells, you know, the goblet cells will produce mucus and the mucus will trap the dust and debris in the air that you breathe in. And then the columnar cells also work there to beat the dirty mucus, all right? The cilia on it, cilia moves in that way. The cilia will beat the dirty out of the respiratory system. Sometimes you can sneeze it out if it's in the upper respiratory. If it's in the lower respiratory, you cough it out. Or sometimes it can even go into your mouth. Some of you may choose to swallow it. If you swallow it and it gets to your stomach, the acids work on it, they act on it, and then if there are any pathogens in there, it will destroy them. It's not always that people sneeze things out, right? So that is the mucosa of the trachea, right? So again, trachea bifurcating to give the right main bronchus and the left main bronchus. The point of bifurcation, we said, is at the angle of the sternal angle, okay? Vertebral level T4, T5. But this point has a special name, okay? This point has a special name. It is called the carina. The carina, that area. It hasn't been labeled here for you, but in the first one, I think it was labeled here. This area is called the carina. Okay, right. So when you go into the bronchus, I'm sure you have noticed that the cartilage continues, the rings of cartilage continues into the bronchi. The plural of bronchus is bronchi, okay? The cartilage rings continue. You see them there, right? Now, when you get into the bronchus, the rings are no longer C-shaped, okay? They are circumferential, okay? Anybody to tell me why the rings at this point will be circumferential? You can raise your hand and I'll unmute you to talk. Why do you think at this point the rings can be made circumferential? Or God made the ring circumferential? Okay, James. James, you can unmute yourself and speak. Yes, those on YouTube, I'm watching, I'm monitoring. You can comment in the chat room. James, you're not ready to answer.
Yeah, I've unmuted now.
Okay.
So it will become circumferential because the esophagus is no longer leaning onto it. It's now going
Exactly.
straight into the lungs.
Exactly.
Yeah, so the trachealis muscle will end at where the esophagus is going. Therefore, becomes circumferential to enter into the lungs. Thank you.
Great. So at this point, the esophagus is right going down. Okay, it's going vertically down like that into the diaphragm and into the abdomen to join the stomach. So these are going to the lungs. So you don't need to make them a C-shaped cartilage. Again, it's circumferential at this point. But then James said that the trachealis muscle will disappear. Actually, it doesn't disappear. At this point, trachealis muscle also becomes circumferential. When you go into the lumen, you see the muscle going all around the whole lumen rather than restricted in the back as seen in the trachea. So please take note of that. Right, so these are the bronchi. Right, we need to keep them open as well. Yes, James, you raise your hand again.
Okay, so like you said earlier, you said the muscle over there was to help so that the esophagus will be able to expand itself. So if the esophagus is no more lining to the branches over there, what then will be the use of the muscle around those places? Thank you.
Okay, the use of the muscle at this point is to support, give extra support to the wall of the bronchi. Okay, at this point, it only gives extra support to the wall of the bronchi. I hope that's clear. Okay. Right, so we move. So these are the bronchi. The bronchi gives off several branches. On the right side here, you see this one is called the superior lobar bronchi. Bronchus is singular, so bronchus. Then there's a middle lobar bronchus here and the inferior lobar bronchus. Now, tell me why you think there are 3 lobar bronchus here. Anybody? Perhaps you have read ahead, so you can say something. Why do you think there are 3 lobar bronchi here? Okay, Sir Gabi.
Yeah, sir, because the right line divides into 3. It has 3 lobes, so the branches also has to divide into 3, unlike the left, which has only 2 lobes.
Exactly. Right. So on the right lung, there are 3 lobes there. Okay. The lung is divided into 3 lobes that are sitting on itself. Okay. They are closely related. 3 lobes. So each of these is supplying one of the lobes on the right. But on the left side, you have only superior lobar bronchus and inferior lobar bronchus. This means that the left lung has only two lobes. All right. I'll show you the lobes shortly. So each bronchus is going to supply, each lobar bronchus is going to supply a particular lobe. Right. Now, the lobar bronchi now divide into segmental bronchi. These are called segmental bronchi. The lobar bronchus is also called secondary bronchus. Okay. Then the segmental bronchus is also called the tertiary bronchus. So these segmental bronchi also go, each of the lobes of the lungs is further divided into segments. Okay. Each of the lobes of the lungs is further divided into segments. Okay. There are 10 segments altogether in the right lung. In the left lung too, there are 10 segments. You can see some numbers here, B1, B2, B3. All right, those are the numbers given to the segments. All right, so each segmental bronchus is going to one segment of the lungs. That is what is happening here. So from trachea, you have the primary bronchi or the main bronchi, and then the main bronchi will divide to give the lobar bronchi. Then lobar bronchi will divide to give segmental bronchi. Now you know why these divisions occur. So it divides serially, okay, into the acid going into the lungs. And we said that the conducting portion ends at the terminal bronchioles. After the tertiary bronchi, we get into what we call the the bronchioles, okay? The bronchioles are also very tiny. They are very tiny tubes. And the bronchioles also divide severally up to the point of terminal bronchioles. Terminal bronchioles are the end of the conducting portion of the respiratory system. Now, there's an interesting thing that is happening as the tubes continue dividing into the lungs. There's something interesting happening. What is happening is that the cartilage, the amount of cartilage gradually reduces, okay? The amount of cartilage gradually reduces. As the amount of cartilage is reducing, muscle is increasing. So cartilage content will come down and muscle content will go up. Another thing that happens, take note, that is point 1. Another thing that happens is that as it's continually dividing, the height of the epithelium is reducing, okay? We started off with pseudostratified columnar ciliated with goblet cells. So columnar cells are tall, right? They are quite tall. But then as it's dividing severally, the height of the epithelium is coming down, all right? Up to a point, here I'm restricting myself to the terminal bronchioles. That is the conducting portion. After that, we'll talk about the respiratory portion. Up to the point of the terminal bronchiole, by the time we are in terminal bronchioles, the epithelium becomes cuboidal. So from columnar, pseudostratified columnar, at a point it becomes simple columnar, then it becomes low columnar, and then by terminal bronchioles, it is simple cuboidal epithelium. As it is becoming cuboidal, the goblet cells will also be disappearing. So this is what is happening. 3 things. Goblet cells are disappearing. The height of the epithelium is reducing, becoming short, and then cartilage is coming down, and then muscle is increasing. In fact, cartilages will end at the tertiary bronchi, okay? And after tertiary bronchi, you don't find the cartilages again. It's gradually reduce and disappear. So by the time we reach the bronchioles, the very first bronchioles, the cartilage is completely absent. So the wall is made up of muscle and the epithelium, which is quite short now. So I want someone to hazard a guess. I said in this discussion, I've restricted myself to the conducting portion, okay? That is from the, we have looked at the nose and the pharynx and larynx already. So here we are looking at the trachea all the way to the primary bronchi, secondary bronchi, that is the lobar bronchi. Secondary is also called lobar, take note. And then the segmental are also called tertiary bronchi. Then bronchioles coming down to terminal bronchioles. Terminal bronchioles is the end of the conducting portion. I said this portion is only piping the air, right? So can anybody hazard a guess why these changes are happening in the structure of the tubes? You can just raise your hand and talk to us. On YouTube, if you know to, you can type it in the chat room. Okay, so Lydia Atta, because the right lung is divided into 3 lobes. You are right. Newman Doku, your hand is up. You want to answer the question? unmute yourself and speak.
Yeah, I want to try. Please, I am thinking the reason why the cartilage is reducing and all other ones are reducing, because we are getting into the respiratory zone. We need more muscles which will contain more vessels for exchange of gases to take place. That is why it's happening. So that is my fair
But
idea.
even the muscles, sorry, I forgot to add. The muscles, although muscle will be increasing, when it gets to the terminal bronchioles, the muscles disappear. As soon as we get into respiratory bronchiole, the muscle is gone. So now I'll tell you the epithelium that is there after this discussion. So see if you modify your answer. So what do you think?
Please come again.
Hey, I'm saying that even the muscle, at a point, although the muscle will be increasing, at a point the muscle will disappear. Just before we enter respiratory bronchioles, muscle will disappear. Muscle will.
The reason is that I am thinking the alveoli will increase over there. That will be the beginning of the alveoli, which that's the reason why there's diminishing in terms of the cartilages and the second one you mentioned.
You are right. You're right. But let's hear James. James also wants to add something. James, what would you add to it?
Okay, sir. So I was just going to say the progressive changes within the structure will be as a result of their functions. Because the function within the trachea would actually be different to the primary, to the secondary, and then to the last aspect within the alveoli. So I'm thinking maybe it's because of the functions that is going to occur within those areas. That is why there is a little bit of a tweak in their changes.
Okay. That is why I said this is ducting zone. Okay. So let's hear Gaza.
What I think is that the reason why all these structures are reducing as it's going forward, as in it's entering the respiratory system, the respiratory duct, or the
respiratory zone.
Yes, the respiratory zone. The reason why it is reducing is that at the end, before it gets into the respiratory zone, we need tiny vessels to enhance exchange of carbon dioxide and oxygen between the blood vessels and then the lungs.
Are you done?
Yes, please.
Okay. So please clap for the people who have answered this question. Wherever you are, please clap for them. You can use the reaction buttons. You'll be clapping for them in class. Sir Gabi, your hand is up. You want to add to it?
Yes, sir.
Okay.
Sir, I want to say that with the goblet cells disappearing in the terminal bronchioles where they disappear, there will be no need for mucus secretion, because by the time it is said that by the time the particles get there, they might have been expelled from the tract.
Exactly.
And also at that point, the secretion of the mucus will block the airway since they are so tiny.
Exactly.
So that there will be obstruction of the airway. Thank you, sir.
Exactly. So you are all bright students. You have made me happy this afternoon. If you were in class, I would have taken all of you who have answered to some fufu joint. That is wonderful. Okay. That is wonderful. That is exactly what is happening. And all the answers you have given me are correct. In fact, you've given me all the reasons why these changes would occur. So, number one, we need a very thin membrane. By the time we get to the respiratory zone, the wall should be very thin, okay? so that the capillaries can easily attach to them. And then as the capillaries are attached, oxygen molecules can move across the walls very easily. Let me get a sheet of paper. I said that the boundary over there is thinner than even paper. So the oxygen molecules can cross easily into you find the capillaries. Assume this is the alveoli, okay? And then this is a capillary. This is a straw, it's a capillary. So the capillary is just attached to it like that, so that the oxygen molecules in the alveoli can cross easily into the capillary, and then CO2 inside the capillaries can cross into the alveoli easily. Imagine if cartilage was there, will it be easy? Right, you two people are clapping for you too. Thank you. Yes, imagine if cartilage was there, will it be easy for the oxygen molecule to cross? You can respond in the chat room. Oh, my question is rhetorical. No, yes. Okay. Imagine if muscle was there. It will be a long journey for the oxygen molecule. Imagine if the epithelium was tall, it's columnar. It will be very difficult to cross that journey. And so that is why these gradual changes will happen. Okay. Yes. Oh, Edward says I'm talking very fast. I mean, naturally, I speak slow, so I have to speak fast. Otherwise, I'll be putting people to sleep. So, Edward, please manage for me, okay? I'll give you the recording too, but I'll try and slow down. Only that if I slow down, you'll sleep. I'll try and slow down so that you get it. But later, you can get the recording and listen over and over again. Right. Thank you. You two people are responding. Thank you. So it's not going to be easy. And so the membrane has to become very thin for this exchange of oxygen and CO2 molecules to happen very easily. Okay. So I've just said by the time we get to, so let me show you another diagram quickly. So these are the things: primary, secondary, tertiary, and then bronchioles will come. And then the last is terminal bronchioles. All right. These are divisions of the, this is where the respiratory, the conducting portion will end. So after terminal bronchioles, the next segment that we'll meet is called respiratory bronchioles. And respiratory bronchioles is the beginning of the respiratory zone. All right. All these things, I have discussed them already. Right. So after terminal bronchioles, we are moving into respiratory bronchioles. And respiratory bronchioles are the beginning of the respiratory zone. All right. It means that from this point onwards, there can be exchange of gases. The exchange of gases, molecules can be crossing into blood and from blood into the airways. All right. So these are the changes. Cartilage increases, epithelium changes, smooth muscle increases. All right. Let me add a point here so that you don't get confused. Smooth muscles doesn't increase all the way to the end. So they increase up to terminal bronchioles and then diminish, okay? Because in respiratory bronchioles, there's no muscle, okay? We don't need the muscle there. Okay. So from terminal bronchioles, this is it. The thing about terminal bronchioles is all here. So we are looking at respiratory bronchioles. So by the time we are in the respiratory bronchioles, this is an illustration of the terminal bronchiole going into respiratory bronchioles. You see that from the point of respiratory bronchioles, these red things you see here are muscles, okay? See that from the point of respiratory bronchioles, the muscles doesn't show, the muscle disappears. And you can see the air sacs or the alveolar sacs appearing at that point too, right? Another thing that you see happening is the blood vessels. These are the capillaries. You see them attached to the alveoli, very closely attached to them, right? Now, from the respiratory bronchioles, who can tell me the type of epithelium that would be there if you were God and you were making the respiratory system? Now you have started with the pseudostratified columna. Now you've come down to cuboidal epithelium at the terminal bronchioles. Now you are moving into respiratory bronchioles. So you pretend you are God. What type of epithelium will you put in the respiratory bronchioles? Mind you, your objective is to reduce the height of the epithelium so that the wall will be very thin. You can type your answer in the chat room, or you can raise your hand and I'll allow you to talk. Yes, anybody? Okay, Bismarck says squamous epithelium. As YouTube, any answers for me? Rexford says transitional. Bismarck, okay, simple type. So you mean simple squamous epithelium? Okay. Yes. I'm waiting for answers. So, Abigail, here we are talking about epithelium. As for muscle, muscle has ended. Muscle ends in the terminal bronchiole. Okay. From respiratory bronchiole, there's no muscle there. Bethy says simple squamous epithelium. Laura, transitional. Okay. From YouTube, Olivia says simple squamous epithelium. Cynthia says cuboidal. Okay, so you continue with the cuboidal throughout the respiratory zone. That's the respiratory bronchiole. Regina says transitional. Ishmael says simple squamous. Anyway, so that is fine. Andrew, simple columnar. No, simple columnar, then you'll be far off because we started with columnar, pseudostratified columnar, came to simple columnar, came to simple cuboidal at terminal bronchiole. So we are going into respiratory bronchiole. So if you are going to make it thin, Salome says simple squamous. So simple squamous is the answer, okay? That is the thinnest epithelial type. So I expected all of you to go for that. So simple squamous, okay? You will not continue with simple cuboidal because simple cuboidal is still a little bit thick, all right? But simple squamous is very thin, it's flat. So that is the epithelial type you find from respiratory bronchioles coming into the alveolar duct. Okay. Right, so please take note. So simple squamous, from respiratory bronchioles through the alveolar duct into the alveoli. From respiratory bronchiole coming, it is all simple squamous epithelium. Right. So now from respiratory bronchioles, you are moving into the alveolar ducts, and then alveolar ducts will open. This is the alveolar duct expanded here for you. Alveolar duct will open into the alveolar sacs or the air sacs, or simply put, alveolus. So these are the alveolus. Plural is alveoli, the air sacs. Okay, so we've treated the airways nicely. Now, these are the capillaries. You see how they wrap around the air sacs. See how they wrap around the air sacs. Right. Now, let's try and identify the vessels. This is the pulmonary artery. It's an artery, but it's colored blue. Why is an artery colored blue here? Anybody to tell us why that happens? Sir Gabi? Gaza? Oh, same people. Let me get some fresh hands. Okay, Elizabeth. Let me hear Elizabeth.
Sir, please, it's an artery. It's blue because it is carrying, arteries carries blood away from the heart.
Okay.
So that artery is carrying blood from the heart to the lungs. That is why it's blue.
What kind of blood is it carrying?
Deoxygenated blood.
Correct. Thank you very much, Lizzie. So the pulmonary, thank you very much for that one. Okay, so YouTube is also responding. Lydia says carries deoxygenated blood. Laurentia says the same. Right. Okay. The chat room is right. So you are all bright students. Thank you very much. So the pulmonary artery is bringing deoxygenated blood from the heart, specifically the right ventricle of the heart. Is bringing it into the lungs. When it gets here, it divides severally and forms tiny capillaries. So those capillaries wrap around the alveoli. Thank you, Sadia. It wraps around the alveoli of the lungs, okay? Right. Now, the blood will be refreshed. CO2 in the blood will move into the alveoli. Oxygen will cross in the reverse direction into the blood. And the blood will be refreshed. That is why at this point, the blood is red. So now the refreshed blood containing oxygen now returns to the heart through this vessel here we call the pulmonary vein. The pulmonary vein will now send the blood to the left atrium. Left atrium will forward it into the left ventricle, and left ventricle will push it through the aorta and redistribute it to the rest of the body. So as you saw in the cardiovascular system. So that is how it is happening. Right. So pulmonary vein is a vein because it carries blood towards the heart. And the blood this vein carries is oxygenated. That is why it is colored red. So remember, the definition of vein or artery has nothing to do with the type of blood it is carrying. It has to do with its direction. If it is going to the heart, it's a vein. If it's coming from the heart, it's an artery. Okay, right. So that is what is happening. And so, you know, the condition called pulmonary embolism during COVID, that condition was very common. Those who got the virus, most of the people who died, their cause of death was pulmonary embolism. Okay, who can tell us what the embolism is? Yeah, anybody? So Gabi, you want to tell us? Okay, Newman.
I want to try.
Yeah, try.
Embolism, my understanding is the blockade of the veins, what do you call it, the arteries carrying blood in the lungs. When it is blocked, the exchange of gas that will take place ceases, and thereby causing suffocation or inadequate oxygen into the system, thereby causing death.
Exactly. So Lydia from YouTube says there's a clot of blood in the pulmonary artery. Thank you, Newman. It's the same thing you said. So those are formation of clots in these vessels, the pulmonary arteries, all right? And they are clotted. It means that the access way to the lungs for the blood to be refreshed is closed. And so the carbon dioxide remains in the person's tissues. The whole body, the body can't get carbon dioxide, and so can't get oxygen. All right. So, eat yourself, Newman. So the CO2 remains in the patient's blood, and you know what it will cause. It will lead to some of the physical signs is cyanosis, and the carbon dioxide will mix with the blood, form acids that damage your tissues and can be fatal. And that was one of the reasons why people were dying a lot due to the COVID. And again, that was also why the blood oxygen levels was always being monitored. You have the pulse oximeter always at their fingertips, checking the oxygen level. When they realize oxygen is dropping, then they have to change your treatment because the likelihood of embolism will be high, right? It's not only COVID, there are other conditions. Obesity is a risk factor to pulmonary embolism. There are other causes of it, right? Joyce, it's not accumulation of air in the pulmonary artery, it's clotting of blood clots in the pulmonary artery, right? So that is it. We move away from here, right? So blood supply to the trachea is by the thyroid arteries and veins, and then the nerves, recurrent laryngeal nerves. Okay, so a bit of a clinical correlation: bronchitis, inflammation of the bronchi. I want you to read about it, okay? Bronchitis is inflammation of the bronchi. It could be due to an allergy or irritation, industrial fumes from factories, or even the car exhaust. If it's too much, that's why you need to be servicing your car engines regularly. Don't be polluting the environment. It could be virus or bacterial causes inflaming the bronchi. Yeah, so that is that. And then there's bronchial asthma. You know how asthma occurs? This is the lumen of the bronchiole, right? Normally it is open like that for air to flow through easily. But in a person with asthma, what happens is that the allergy triggers the release of mucus. Somebody mentioned that you don't need mucus at the respiratory bronchioles. If mucus gets there, it's going to block it. This is what happens in asthma. So the allergy will cause excess production of mucus, and the mucus gets in so thick and blocks the bronchioles. When it blocks the bronchioles, another thing that happens is that the muscles also contract. All right. This is happening at the level of the terminal bronchioles. Muscles will be contracting, and when the muscles contract, it reduces the size of the lumen. Okay. There's mucus and there's muscle contraction, so the luminal size is reduced. So this person will now be struggling to breathe. You see, the airway has been blocked. And so you find people with asthma, when they are having an attack, you hear a wheezing sound in their breath. Hear that wheezing sound in their breath, okay? That wheezing sound is because of air struggling to pass through a very tiny space, right? Because the mucus leaves only a tiny space for the air to go. See, almost breath to get the air in. You feel their chest tipping in and out like that. They're struggling, doing all they can to gasp for breath until they get something that would relieve the allergy. And that is the most common one, is salbutamol. In more severe cases, they have to get the Ventolin inhaler or be nebulized. They have to be nebulized. And nebulizer also uses a higher concentration of the salbutamol and some other decongestants to help clear the airways, to clear the allergy. The constriction will be relaxed, the mucus will be cleared, and the person can breathe normally. There are a lot of triggers. Some of the triggers could be emotional, some shock, broken hearts can even cause an asthma attack. It could be some food the person is allergic to. It could be dust, even dust can cause that, or some strong perfumes, okay? So if you have a roommate who is prone to asthma attacks, you are not permitted, okay? God does not permit you to use strong perfumes and those things. It can cause problems for them, right? Roots.
Sir, please, good afternoon.
Yeah.
Sir, please, I want to ask about asphyxiated babies who are asphyxiated.
Mm-hmm.
What happens to them too? Do they
Yeah,
also go through the same thing as the asthmatic patient?
Something very similar, only that theirs is not happening at the bronchi, at the bronchial level. It is happening in the throat, in the pharynx. So the food they've eaten or fluids coming from the GI tract get to fill the pharynx, okay? And the pharynx communicates with the airways. So when it is filled like that, the fluid has nowhere to go and can find its way into the larynx and then the trachea and block the airway. Asphyxia can happen in the adults too, especially people who drink a lot and don't eat well. You might fall asleep and in your sleep be vomiting unconsciously. You find that the vomiters will come and fill your throat and block the airways and you can die.
Okay. Thank you very much.
Right. Gaza. Who is Gaza? You should be using your real names here. Mm-hmm. But your hand is up, so unmute yourself and speak. Gaza. Perhaps it was accidental, so let's go on. Right, so that is asthma. Right, bony thorax, please revise your notes on the skeletal system, okay? Take a look at the bony thorax again. The components of the bony thorax are the ribs. There are 12 pairs of them, 12 on each side, and anteriorly they are connected to the sternum. That's the sternum. This is the manubrium. That is the body of the sternum. This is called the xiphoid process. They are connected via costal cartilages, but interestingly, only the first 7 ribs have their own costal cartilage connection to the sternum. And so we call them true ribs. Rib 1 to rib 7, they have their own costal cartilage connection to the sternum. So we call them true ribs. Ribs 8 to 12 do not have their own costal cartilage. So they are called the false ribs. You see that 8 will join that of 7 to go. 9 will join that of 8, and 10 will join that of 9. But then the last 2, 11 and 12, they don't have the cartilage at all. So they are not even connected to the sternum. So we give them a subcategorization as floating ribs. The sternum, this is the point I was telling you to palpate, the sternal angle. Okay, that's the body of the sternum, the body and the manubrum. So this joint is what we call the sternal angle of Lewis. It is the point at which the T4, T5 vertebra can be located, and that is the point at which the trachea bifurcates into the main bronchi or the primary bronchi. And then posteriorly, the ribs are connected to the thoracic vertebra, the 12 of them, T1 to T12. Right, so that is the bony thorax for you. So please revise your skeleton, your notes on the skeleton. Okay. And then introductory anatomy, you did the body cavity, so we won't go over that. Right, so we look at the lungs, and then we look at the respiratory membrane, and then we bring our discussion to an end. So there's a covering on the lungs, okay? There's a serous membrane covering the lungs. It's called pleura, okay? It's called pleura. It's double layered, okay? It's a double layer. Assume that is the lungs. So you have a double layered membrane covering it, all right? The inner layer that is in immediate contact with the lungs is called the visceral pleura. And then the outer layer, it lines the inside of the thoracic cavity. That is called the parietal pleura. So the space in between the 2 layers is filled with a serous fluid, a fluid that is watery in nature. It serves as a lubricant, it lubricates so that as the lung inflates and deflates, slide against each other nicely. There will be no friction. Someone is asking a question on YouTube. Okay, so that is the pleura. So this is the lungs, the surface of the lungs, and then the pleura covering the lungs. So that's the lungs again with the pleura. You can see the lungs, they sit on, this is the diaphragm. The lungs will be sitting on the diaphragm nicely like that. This anterior view of the lungs, posterior view. You can see the pleura, okay. Just notice that the pleura descends further downwards, okay, beyond the limit of the lungs. The pleura, we call these recesses. So if you accidentally puncture this part, you are not going to puncture the lungs, but you puncture the pleura. and then it can cause blood or air to leak into the pleura, and that can interfere with breathing. When air enters pleura, we call it a pneumothorax, P-N-E-U-M-O, thorax, pneumothorax. When blood enters, it's called the hemothorax. That interferes with the breathing. It usually happens in accidents. Find metals piercing people's chest and causing pneumo and pneumothoraxes. That interferes with breathing. Right. Yeah, so that's the spelling of pneumothorax and hemothorax. So these are the lungs. The lungs has three surfaces. This is the part that sits on the diaphragm. We call it the diaphragmatic surface. And then this part faces the heart. We call, or the mediastinum, call it the mediastinal surface. And then the opposite side, the other side of it faces the ribs. So we call that the costal surface. So those are the surfaces of the lungs. At the mediastinal surface, you find the hilum of the lung. That is where the structures that enter and leave the lungs are found. These are the openings from the bronchi. That's the openings for the bronchi that are entering. This is the right lung, okay? You can see three lobes here. This is the superior lobe, all right? That is the middle lobe, and that is the inferior lobe. There are fissures that create the lobes. So there are two fissures here. You can see this line here is a fissure. It's like a cut through the lungs, a division. This is called the horizontal fissure, and this is called the oblique fissure. That is what creates the lobes. So superior lobe, middle lobe, and inferior lobe. Back to the hilum. So the opening for the bronchi, and this is the opening for the pulmonary arteries, and this is the opening for the pulmonary veins, right? When you go to the left lung, we said there are two lobes in the left lung, superior and inferior lobe. So you have only one fissure, all right? It's called the oblique fissure. Then this is the hilum of the left lung. You find the opening for the pulmonary artery here, the opening for the bronchi, and then the opening for the pulmonary veins, the point at which they enter the lung. But you can find also depressions on the lungs, okay? There are depressions, but we won't go into them. Just note that the organs that are in close contact with the lungs make impressions on them, right? The most prominent of those impressions is this one here, we call the cardiac impression. It is found on the left lung. This is the left lung. You know, the heart bulges more to the left side. So it creates a big depression in the left lung. We call that the cardiac impression. Right, so that is the lungs. Now, let's go to the respiratory zone. So, James, unmute yourself. Your hand is up.
Okay, sir, thank you. Please, the fissures that has appeared on the lungs, I want to ask, why are they there? Is it through developmental stages that they came about?
The developmental stage.
Oh, okay.
Yeah, they are formed during the developmental stage.
Okay, thank you.
And then the divisions, let me chip this one in. One clinical importance of the divisions in the lobes of the lungs into segments and all is that when there's a tumor affecting the lungs, okay, a segment of the lungs can be taken out, all right? Just if the tumor is affecting a segment of the lung, that segment can be removed without damage to the entire lungs. There are membranes separating the segments, so you can remove that portion without damage to the entire lungs. So we learned there are 10 segments in each of them, all right? So you identify the segments that have been affected and you can take them out safely without damaging the rest of the lungs. Please take note of that. Okay, so we are back to the tubes again. We'll be ending shortly. So again, terminal bronchial, respiratory bronchial, getting into alveolar duct and then alveolar sacs. Okay, so alveolar duct and alveolar sacs, and the capillaries that wrap around the alveoli. Yeah, Ismail on YouTube. That means we can have a lobar infecting necessarily the entire lung. The question is not clear. Ismail, please come clear. Okay, so this is what we call the respiratory zone. So what you see here is the alveolar sac, okay, the alveolus, and these are capillaries going around it. So you see this black circle here. The black circle is circling the junction between the point where the capillaries are attached to the alveolus, and that has been magnified over here for you. All right, so over here is a space inside the alveolus, and this is the capillary. You see how they are attached. Very thin space. This is what we call the respiratory membrane. Okay, it's made up of the epithelium of the capillary, the epithelium of the alveolus, and then their basement membrane. This is the basement membrane that has been fused together over here. So oxygen is moving from the alveolus into the capillary, and CO2 is moving from the capillary into the alveolus. And that is a red blood cell. I hope you know that it is a red blood cell that contains the hem molecules, what we call hemoglobin, the protein with the molecules, and the molecules trap the oxygen. All right, the hem is what traps the oxygen and the CO2. It will go and to pick the oxygen from here, get to the tissue level, release it, and pick CO2 and bring it back here. All right, so it's the red blood cell that does that. So, okay, he says we can have lobar infection, not necessarily the entire lung. Yes, you can have some infection or inflammation affecting particular lobe. Even tumors and cancers. Yeah. Right. So this is what we call the respiratory membrane. When you see it, don't let it be a very strange structure. All right. Right. So the wall of the alveoli have two cell types. We have the type 1 cell and the type 2 cell. The type 1 cell is the squamous cell. All right. It's a squamous cell in the wall of the alveolus. The type 2 cell is the one shown as green over here. It's called the surfactant secreting cell. It produces surfactant. It's a protein that lubricates the surface of the alveoli. When the surfactant is lost, there's friction over there and the breathing becomes difficult. That is what we call pulmonary emphysema. Pulmonary emphysema. You can read about pulmonary emphysema. That is when the surfactant secreting the type 2 cells are lost. These cells are also called pneumocytes. So some say type 1 pneumocytes or type 2 pneumocytes. But take note that the type 1 is the one that is a squamous cell forming the wall. and the type 2 are found in between the alveolus. They produce the surfactant that lubricates the surface of the alveolus to reduce friction. Someone was asking about nebulization and preterm care. This is where it happens. So in preterm babies, you need their lungs to be working, all right? Need their lungs to be working. So what they do for them is called surfactant nebulization, all right? Which improves the secretion of surfactant, all right? In the preterm infant, so that their lungs or their alveoli will function normally. Friction over there will be reduced and there will be no inflammation over there. Otherwise, they may get respiratory distress syndrome, and that reduces their chances of survival. So they do surfactant nebulization. That was the question Epiphania was asking. Right, Newman, your hand is up.
In your meeting, the harm is the oxygen carrying body, or it helps carry
hemoglobin.
So I want to ask, if somebody is anemic, won't it affect breathing?
Exactly. So anemia is a reduction in your hemoglobin levels. Okay. There are several types of anemia. Iron deficiency, folate deficiency, is it megaloblastic, whatever anemia. And when you do hematology, they will talk about them. So they are all by B12 deficiency can also cause anemia. That's called pernicious anemia. So all these types result in one thing: reduction of your hemoglobin levels. Okay. And so when that happens, it means that your blood's ability to trap these oxygen molecules, you'll be breathing all right, but the ability of your blood to trap the oxygen has been reduced. So it's not delivering enough oxygen, all right? When assuming the normal HB level for women is 13 to 14 or 15, for men it is, for men it's 13 to 15, and then for women it's 11 to 12 or 13. You know better, you are on the ward. Yeah, so if it is reduced below this level, it means that you don't have enough hemoglobin molecules to trap this oxygen and even to remove the carbon dioxide from your system, all right? So it becomes a problem for you. You need to work on building it up. So they'll give you the hematonics, the blood tonics to boost your HB levels, or they will have to do, if it is below 7, I think HB below 7 requires transfusion. Transfusion would have to be done for you so that your red blood cells will be increased to pick up more oxygen. In sickle cell people, they have a problem. They have an abnormal form of the hemoglobin. That is, there are different types of hemoglobin. There's hemoglobin A, there's hemoglobin S, hemoglobin C. There's even one called fetal hemoglobin, hemoglobin F. But then the normal one is the A. The A is the one that binds very well to the oxygen. So if you have these abnormal types, some people are AS, your sickling genotype is AS, it means you have hemoglobin A there and some amount of hemoglobin S. So for you, the A will compensate for the S and you can be okay. But then for those who have the SS, it means that the genotype is completely abnormal, right? They have abnormal 2 genes, all right? Both are abnormal hemoglobins, and they cannot bind well to the oxygen. So for such people, they always have to be in an environment with a lot of oxygen, the moment they are in an environment with reduced oxygen, then a crisis will come. A crisis is triggered because the hemoglobin now is abnormal. So it is just managing. According to a car, netai ajua 90. All right, the tire have no pressure. All right, but if the air comes from the tire completely, the car won't move. All right, your rim will be destroyed. So that is the case. So in SS case, it's unable to bind very well. So if you reduce oxygen in the environment, the atmosphere for them, they are in a stuffy room, or those people didn't do well with nose mask at all because it resists or restricts the flow of oxygen. Okay, if that happens, then they go into a crisis and in the crisis state, the hemoglobin molecules or the red blood cells would assume a sickle shape, a shape like a sickle, all right? And this sickle shape can easily interlock. And when it interlocks like that, it blocks the blood vessels, and that causes more problems for them and more pain for them. And they would have to be put on antibiotics, anti-inflammatories that will reduce the crisis. And severe cases, they have to be transfused, put on oxygen as well. So that is what happens in those hemoglobin types. Right, so in the absence of any other matters, we'll be ending our discussion over here. YouTube, Salome is asking, aminophylline and caffeine given to preterms, are they also surfactants? No, they are not surfactants. They work to trigger what do you call it, muscular contractions, you know. Oh, who is saying, say I'm not happy? Why was the problem? Yes, so they work to trigger muscular contractions. They work to trigger muscular contraction. You know, respiration, there are muscles of respiration, the intercostal muscles in between the ribs, the diaphragm, and then some of the back muscles, even in forced respiration, the levator, scapulae muscles, and all come in there. This big one here called the sternocleidomastoid muscle. It also plays a role in forced inspiration, right? All these muscles are there to help increase the volume of the thoracic cage and reduce it during breathing in and breathing out, respectively. So you need, if a baby preterm is not breathing well, that aminophylline and then caffeine can be given to trigger this muscular activity, specifically the diaphragm, okay, so that breathing can be facilitated. This is how the diaphragm helps in breathing. When the diaphragm is relaxed, okay, it is dome-shaped, all right? And that reduces the volume of the thoracic cage. And so if there's any air in there, the air in the lungs, the air will be forced out. When the diaphragm contracts, it flattens out. And when it is flat like that, it means that the volume of the thoracic cage has been increased and the lungs can expand to take more air. So that is your aminophylline and caffeine triggering diaphragmatic activity and increasing respiration. Can breathe. The baby will be able to breathe very well and increase the chances of survival. It also facilitates the removal of carbon dioxide from the body. Whoa, what is she saying? The name is Baby. Who is Baby in the class? Then she couldn't get all I was teaching. How? Dora says, at what age can someone with sickle cell start showing signs? That one there, right from birth, no. Right from birth, you can see certain things. That's why they will prick the heels to do the electrophoresis. But it's very good that you know your status, your sickling genotype, and that of your husband. And so you know your chances. I mean, if you're in a relationship now, get to go to a lab and go and do the sickling test and the HB electrophoresis. Usually people end at the sickling test when they hear, because you know that when both of you are positive, there's sickling positive, there's a problem. When they hear they are sickling negative, it ends there. And the partner is sickling positive, it ends there. No, it shouldn't end there. Whether you are positive or negative, go and do the electrophoresis, all right? Because the sickling test only reveals the hemoglobin S. But I told you that another abnormal hemoglobin is called hemoglobin C. That one, you won't see it at the sickling test. You only see it at the electrophoresis. So imagine that you are AS and you marry somebody who is AC, because the AC person will come up as sickling negative, okay? And you go ahead and marry because think you are balanced. The AC, you are AS and you marry an AC person. You have a chance of giving birth to a child with SC. So 2 abnormal hemoglobins. That is also another form of sickle cell disease. And so very important. Don't just do sickling test and go ahead and do the electrophoresis. HB is called hemoglobin electrophoresis, and that will reveal the type of hemoglobin in you. A lot of people have relied on sickling test and have regretted, because now they are giving birth to kids with sickle cell and they don't know how it happened, but it's because of C, the hemoglobin C. So do that. And when is it's better to break the relationship at that point than to go in there and cause a child to suffer. Don't do love. So you love yourselves and you give birth to children that will come and suffer. Don't do that. At what age? Okay, I've answered that. What's the significance of surfactant in lung function? Oh, it lubricates the surface of the alveoli. Okay, you see the alveoli are, imagine you have tiny balloons, all right, all put together in one sack, and they are all inflating and deflating at the same time. The balloons will be scratching against each other. If you're not careful, some will be bursting and they'll be damaging. But if you have oil around them, all right, they'll be sliding nicely against each other as they are inflating and deflating, and then they won't be bursting. And those of you who do decor, and those of you who are wedding crashers, you like wedding jollof more than anything. So whether you are invited or not, you go. When you go, you see the balloons they used for their decor, small time, pop. It's because of the friction between the balloons causing the damage and the old best of. Imagine if there was oil some oil or some lubricant on their surface, there will be no friction. Your balloons will be there nicely for you. So it's the same thing. The surfactant acts as a lubricant for the surface of your alveoli so that as they are inflating and deflating, they slide against each other nicely. There's no friction and there's no damage. Okay. The correct pattern for respiration. Please check, Google that. There's a respiratory rate. There's a normal respiratory rate. And please check that. Abigail has seen somebody with SC. Yeah, it is there, but people are not catching it. People are not catching it because, oh yes, cycling test, they can say, oh, we are cycling negative. They are okay, but cycling negative can be somebody with AC. So if you're not careful, you go and marry an AS person, you get an SC. I'll send you a picture of the cycling genotypes and their inheritance. Or you can Google and find it, okay? Yeah. I used to do a lot of radio talks and presentations on this, trying to get people to test and don't end at the cycling. And the churches too are the cause. Most of the marriage counseling forms you get, they just write cycling test there. And microscope in a mouse can be cycling negative. No. So if you're in a church and you're influential, modify your marriage counseling form, the lab request, and include HB electrophoresis. You help a lot of people. After all, marriage counseling doesn't mean that you marry. Counseling can end in two ways. Either you realize you are incompatible psychologically, socially, medically, and so you have to stop the marriage, or you realize that you are compatible psychologically, socially, spiritually, medically. So please help your churches. Can someone be born with asthma? Yeah, asthma is hereditary. Whilst growing, yeah, it can also be acquired. Yeah. Betty says I'm scaring her. And then watch your boy be home. And then I made this girl. Please, your voice is still down. Oh, Eric, people can hear me. We are even giving birth cry before marriage nowadays. Anyway, it is happening. I mean, people are doing it. But and so if you are in a relationship, it's good to know your cycling statuses and your HB hemoglobin types. It's good to know. Don't wait till you get to marriage counseling. Once the boy comes now. So there was something we used to do. I think I have a copy here. We call it the medical ID. It was something when we did the teachings. I don't know if you can see it. This one is actually for my brother, so I don't mind showing it to you. Yeah, that is it. It bears the person's blood group and resource, and also bears the cycling status and then the hemoglobin type. Okay, so if you do this and you keep, if you meet somebody, the person comes to propose to you, and just like Ghana card, you ask, oh, now, oh, medical card, I mean, sure. So you check, you see the person's HB genotype, and then you also have yours. You check, oh, Charlie, with the EMFA. Or go to your next target. Now, more transfer. Okay. Just at the point of proposal, you can just clear this one. Than to wait, you fall in love, test, you're incompatible. So they say we'll be managing, so good there, you manage. It's not easy if you live in a family with somebody having sickle. It's not easy. The hospital becomes more or less your second home. It's not easy. So let us not be risking that. Oh, Mukaila, if you want the card, we can talk in private. We can talk in private. It's very important. All right. So it's been nice talking to you. We've already crossed 3 p.m. It's 3:21. So we have to end here. I have a meeting, and so I have to leave you. I have a meeting at 4. I have to be going. I wish you well, and God bless you. So we'll meet again, and we've done respiratory, lymphatic. We'll meet again for male reproductive system, and then I think endocrine, hopefully next week. So have a wonderful weekend. Bye, bye, bye.